This is GIT number 9, Brain Studies for the Small Intestine. This is prepared by Prof. Sharaf and revised by Prof. Hanisami. This is what we call enterocolitis. Appearance of enterocolitis. Here are multiple jejunal diverticula. With neck. A lot of diverticulae are seen scattered all over. This is the typical appearance of annular carcinoma involving tubular structure. The same appearance can be seen in the duodenum, can be seen in the esophagus, can be seen in the colon. It is annular structure. Dilated small bowel with no mucosal folds can be seen as in small bowel obstruction. Sprue and scleroderma. This is sprue, dilated loose without mucosal thickening. Multiple small bowel masses can be seen in polyposis, lymphoma, and deposits. This is the appearance of multiple polyposis. And of course, the multiple nodularities and polypi can also be seen in lymphoma. Separation of the small bowel loops from each other maybe due to thickening of the wall, carcinoid tumor, Crohn's disease, the presence of ascites, peritoneal metastasis, and mesenteritis or retractile mesenteritis. These are the separation of the loops due to the presence of a lot of lymph nodes. Could be a sign of Crohn's disease. In bone marrow transplantation, at sometimes you may get such an appearance due to GIT viral infection with separation of the loops. Ischemic enteritis with narrowing and submucosal hemorrhages can present in ischemic enteritis as several loops. Mesenteric hemorrhage can present with some printing along the small intestinal involved loops like this, here and there. Mesenteric hemorrhage. This is the esophagus. This is a pouch of the fundus, and this is part of the body, and there is large irregular thickening here of the outline, with converting into the remaining part of the pylorus into a very narrow lumen reaching the jejunum. Gastrojejunostomy with gastric carcinoma at the site. Mid-gut malrotation. In a newborn, there is no gas in the middle and lower quadrants, and the main lobes are seen on the right side. In adults, this is the appearance of the small intestine on the right side, where the colon is shifted to go to the left side here. Malrotation. If you look carefully, you will find small nodulations involving the jejunum, small nodulations. This could be due to, again, lymphoma, first possibility, and agammaglobulinemia. This a blind loop, and this blind loop indicates a amical diverticulum with the fibrous tract or omphalomesentéric duct if there is a patency here. So patent is called omphalomesentéric duct, closed called fibrous tract, and this is the appearance of the blind loop inside. This is typical appearance of Crohn's disease. As we get diseased parts, skipped parts, diseased, skipped, etc. So skip lesions, number one. Number two, the lesions is eccentric, more involving this side, mesenteric side, rather than this side. Narrowed lumen, irregular lumen, ulcerating lumen, pseudobulbi sometimes. These are occurrence of appearances of Crohn's disease. In Crohn's disease, again, you can find irregular segments of narrowing alternating with segments of normal caliber, and the mucosal irregularity is seen very well, denoting Crohn's disease. Ileal Crohn's, we have seen this before. Enterocolitis shows nodulations. And here we have some fistula resulting in filling of the part of the colon. Here is the fistulation. And these are some of the appearances of Crohn's disease. Again, this one, Crohn's disease with carcinoma formation. This is a large mass within one of the ileal loops, and the ileal loops is irregularly involved. Some are normal caliber, some are narrowed, and we have the mass, and then we have irregularity. This is typical appearance of Crohn's. Crohn's is a disease which can affect one side of the loop, sparing the opposite side, and it is essentially formed of nodules, irregularity, submucosal ulcers, pseudopolypi, and it may be complicated with carcinoma or fistula. Again, Crohn's disease, thickened, irregular, multiple narrowing with involvement of the small intestine. This is how ascariasis can be seen within the intestinal loops. This is one of them. And here, while swallowed the barium, the contrast, and here the one vision by ultrasound. Here is the terminal ileum is involved in a process of irregularity and narrowing. Of course, amongst the diagnosis is Crohn's disease, but this proved to be terminal ileal endometriosis, implantation of uterine endometrium. We have a lot of things, so giving to cross course crossing, or coarse intestinal mucosa, coarse intestinal mucosa. Loculated contrast along small intestine from prolonged use of drug. The NSAID is the group of drugs called non-steroid anti-inflammatory. The prolonged use of such drugs can result in such an appearance. This is an appearance of carcinoid, a tumor with radiating coronal sign. Filling defects along the lumen, mass along the lumen should be investigated as a carcinoid so long there is clinical symptoms and signs of carcinoid syndrome, because in small intestinal carcinoid is usually associated with carcinoid syndrome, which compromise flushing, compromise diarrhea, which compromise sometimes hypertension. Hypoalbuminemia results in thick mucosal outline, or what we call congestion. Is a general congestion due to low albumin in the blood. Edema, it is a sort of edema of the loops. This is interception, where a loop is going inside another loop. Loops are seen within the colon. Small bowel interception. Loops within loops, loops within loops, again loops within loops, and here is the target sign typical of interception. Masses, which are mainly exovitic, are typically of lymphoma. Of course, if you go to the story of lymphoma of the small intestine, it will result, as we said, by small nodules which may be coalescing and forming larger nodules, masses, and extending outside, and we have endophytic and exophytic components. This is ileal lymphoma, where a lot of masses so separation is there due to lymph nodes, and narrowing, segments of nerve due to compression, and maybe with fissuration sometime. So the differential diagnosis could be Crohn's, could be lymphoma. Typical lymphoma with large extraluminal exophytic component with ulceration inside and excavation, presenting as aneurysmal dilatation of the small intestinal loops. Aneurysmal dilatation. Among the appearances of segmenting of nerving of nodules, masses, and exophytic tumors is the presence also of aneurysmal dilatation due to large masses, which is excavated and continuous with the lumen of the loop. Of course, fissuration is another possibility. Here is the typical appearance of a GIST. And the GIST here is showing as large soft tissue mass outside the lumen, but definitely adherent and continuous with that part of the loop. So it has a very large exophytic component. Here it is a leiomyosarcoma. So lymphosarcoma, leiomyosarcoma, and fibrosarcoma are different types of this which can affect any parts of the intestine and stomach. Now serosal deposits appearing here as a bulge, or here as segments of narrowing and non-filling and separation, and here as another bulge. This serosal metastasis can occur from ovarian or pelvic malignant lesions, or coming from gastric stomach, gastric carcinoma with seedling. If you look here, this is a terminal ileum where a mass is around, causing enlargement with a very narrow loop inside, and it proves to be lymphoma presenting as bowel thickening. And here is Crohn's ischemia with multiple loops showing small bowel thickening. So small bowel thickening is the main presentation in small intestinal loops, but of course the pattern of thickening, if it is smooth, continuous and long segment, it will be different from a short segment of mass-like effect compressing the lumen. This, the first of longest involvement, should raise the possibility of Crohn's. And if there is something acute, ischemia is a possibility, and if it is ileocecal, so please look for TB, also lymphoma and Crohn's disease. The duodenum can have adenocarcinoma mass, and the same as in the rectum. Both are showing as marked thick wall encroaching on the lumen, markedly thickened wall encroaching on the lumen. So the behavior is almost the same, and the pathology is either a polypoid mass, a large malignant ulcer, or annular lesion, or infiltrating processes like rhinitis plastica. If this is a small bowel, the site of transition from normal to abnormal. This is abnormal, this is normal. This is thick walled with narrow lumen, this is normal lumen with some dilatation. It is important to locate the site where obstruction is there, because we have to have a method of defining and describing small intestinal obstruction. Now look here. This, if you look at this group of loops, definitely they exceed 3 centimeters. So 3 loops more than 3 centimeters showing more than 3 fluid levels like this is considered diagnostic for small intestinal obstruction. Our aim is to locate where is the site of transition between normal and abnormal, like this area. Here is edematous thickened small intestine, edematous thickened small intestine. Edema, of course, can occur in hypoalbuminuria. Here is amount of fluid inside the pelvis due to ascites. Target sign or pull sign of alternating density, noting edema of the loop. Here we have one of the vessel is not enhanced. This is the superior mesenteric artery. There is ischemia, and here is the dead loops showing pneumatosis intestinalis, how air is seen in the wall of the smaller loops, and how air is reaching into the portovenous region, so tract, so it is portovenous or portal venous air. So we have sequelae of superior mesenteric artery thrombosis as non-filling, thick-walled loops, pneumatosis intestinalis here and there, and the presence of portal venous air. What is this? This is an example of how CT can do reconstruction and shows a small intestine filled with fluid like enterocolitis. Thank you.